So I'll start off this afternoon talking about patients. And this is for patients and families. Who needs a fusion with Chiari malformation? It's always been a big question. It's a question still, I would say, that's debated in the literature and neurosurgery literature at conferences. And some people have never ever fused anyone with a Chiari malformation. You can say, well, why is that? Well, it may be because the referral practice that they have. And so it all depends on how many patients you see and the variety of type of patients that you see. So if you're doing 50 Chiari surgeries a year or 30 Chiari surgeries a year or something like that and seeing numerous patients, then you're bound to come across, cases that don't look like the typical Chiari cases that I've probably shown you already, and you'll see, and most typically see. And these are ones that they have a Chiari malformation, but they also have additional problems. They have a bony problem or they have a ligament problem associated with the craniocervical junction that then, what you'll see in these images I'll show you, creates problems from the compression in front of the brainstem as well as blocking CSF flow. Without doing some kind of additional decompression besides the back and stabilizing the spine, the likelihood of having a good outcome is very poor. So these are more rare cases. So the very first fusion associated with the Chiari malformation was done here at the University of Iowa, and this was in the 1980s. It's by Arnold Meneses, who we're kind of honoring with this year's conference. Unfortunately, he couldn't be here due to some health problems, but this was done in the 1980s and reported in 1988, and this is the cases that he reported in that manuscript. It was for fusion for stabilization after decompression from the front. This is after a transoral procedure and then realignment of the skull and spine. And this was this approach, and it was because of going on from behind, as you saw before we do this decompression, but in this kind of case, you can see there's this large compression from in front, putting pressure on the brainstem here, right? And cases like this, you can imagine if you just do a decompression back here, it's not much you're doing, really. You can take off the bone here, you can take off the part of C1, but there's not much room to go backwards, right? Because of what's being pushed in front. So the goal in these cases is to realign the spine. And back then, it was to do a transoral decompression. You go through the mouth and take out this odontoid. Now, I'll talk about our approach now. It's changed with modern instrumentation. But the goal was to decompress in front and then stabilize behind with the fusion. This was a 10-year experience, 72 patients. And patients did quite well with this. And this is one of the first reports showing this. Prior to this, many people thought this transoral procedure was high risk and had a lot of risk of complications, infections, and so forth. It was this paper and a paper prior to that that showed that, hey, look, this is a lot safer if you do a certain, just based on technique, right? Like, using a lot of antibiotics, at the site and back of the mouth, a lot of preparation and things like this could really limit those kind of infection risks and other risks. All right, so which patients with Chiari need a fusion? And we know that a posterior fossa decompression is effective at treating Chiari. I showed you see plenty of examples of that. That will be offered by many surgeons for the most common types of Chiari malformations. However, some patients with Chiari have these bony ligament. These are congenital and acquired, in some cases, abnormalities where the skull meets the spine. And that leads to this bony abnormality that causes compression in front, either from bony abnormality and growth and abnormalities of the bone, or just ligament instability. But oftentimes, it's really a combination of both. This can lead to instability and misalignment. And it's really, in today's treatment, how we think about this, it's really not just a fusion, okay? It's not just, we're doing a decompression and a fusion. It's patients need realignment, right, into a new normal bony position. And then the fusion really is the instrumentation we put in the back is just to maintain that normal alignment, okay? This is just the anatomy. I'm going to go over this so you kind of understand things a little bit better detail. But this is the craniovertebral junction or the craniocervical junction. This is the occipital bone. This is looking from the side, this right here. So this is the side view. This is the first bone of the neck, C1. They also call this the atlas because in mythology, atlas is what held up the globe. So in C1 is holding up our head, right? C2 is the axis, and that's what rotates. So C1 rotates on C2, so that's why it's called the axis. And there's a little peg that goes up from C2 so that C1 and then the skull can rotate on C2. One thing I'm showing here in the side view is see how flat these joints are, okay? This is unlike any other spinal joint. Every other spinal joint, it's a hinge, and it's a little bit more configured, so it provides more stability. These are flat joints because a lot of motion of the neck, of flexion, extension, and rotation occur here. So to allow it to happen, the joints have to be flat, okay? So you can get more motion out of it, right? So the more restricted and stabilized a joint is, the less motion you're going to get. These are made flat, so these are flat on purpose. What holds them really together are ligaments. So you can imagine if you have a ligament issue, some hypermobility, then you're going to get more motion at these joints here, where the skull, the occiput meets C1 and C1 meets C2. And because this is really kind of a complex bony ligament complex, that's why so many congenital genetic problems affect this area here. This is just showing like another view. That's that little peg that sticks up from C2, so C1 can rotate on that little peg. The only thing that really holds C1 to C2 is a ligament that goes right behind this, okay? And there's some ligaments here that help stabilize the joints. Obviously, there's neck muscle, too, that helps and stabilize things. So if you have a lot of neck muscle, that will help your stability. That's true for every joint in the body, right? And obviously critical here in the neck, too. So here's the ligaments. I'm just really showing this not so you can understand all this, but show the complexity of the ligaments that occur and the amount of ligaments that occur just between these three bones, okay, and these two joints, all of these ligaments here, okay? So you can imagine that's what's stabilizing the head on the spine. And again, a ligament problem, hypermobility problem, connective tissue disorder is really going to disrupt this. All right. So this is all the pathology, all the diseases, the disorders, the problems that can occur that we've seen, congenital and acquired abnormalities that occur with Chiari malformation. These are not all of them. Okay, there are more, but I put like really the most common ones that we've seen. Right, this list could probably be 3 times or 4 times as long. But here's all these bony abnormalities, and this is not like the cases I kind of showed before. Those are all pretty normal, okay? But they can have all these abnormalities at the skull base, which are here, the atlas, which is C1, and then C2 and C3, which are here, okay? Then ligament abnormalities, you can have ligament abnormalities all at the occiput to C1 and C1, C2, and down. There's all these associated syndromes, too, that you'll see Chiari with that create a little more of a complex picture. And they all have, again, bony abnormalities with them and ligament abnormalities, or one of each, or one or the other, I mean. So Klippel-Feil, again, you'll see bony fusions that occur that are congenital. They create a little more complex picture and lead to more instability. Morquio syndrome, Vactorel syndrome also creates fusions of the bone and creates instability. Or there's Danlos syndrome in the most severe type, where you have severe hypermobility. And there's many more. Other things we can see in inflammatory conditions as well can be associated with Chiari. We've seen that, as well as juvenile rheumatoid arthritis. We've seen that in kids associated with Chiari malformation. I put this down here because people will use this term a lot in the literature. You may hear this, and there's basilar invagination. Oh, I have basilar invagination, And I just want to make a comment that this is really not basilar invagination is not a bony abnormality. It results, though, from bony problems and ligament problems, right? So any of these conditions here can cause basilar invagination, okay? People talk about this acute clavicle canal angle as they measure this, and okay, this patient needs a fusion because they have an acute clavicle canal angle. But again, it's way more complex than that. And I've had plenty of patients that have acute clavicle-canal angles that I never do a fusion on, and they do absolutely fantastic. They have no brainstem compression from the front or the back, either after surgery. And so this is just also, this depends on these abnormalities here, and the clavicle-canal angle. It just helps to kind of delineate. Oh yeah, well, this is acute clavicle-canal angle because of maybe one of these problems, and whether you need a fusion or not just depends on many other factors, which I'll kind of talk about. All right, this is just a slide showing you each of these are a different patient, okay? But they're not what you just saw like previously in my initial presentation. But this is a side view of your brainstem here and your spinal cord. You can see this bone here is going back into the brainstem, and you can see then the tonsils are coming down here. It's a large obstruction because you can see how big the fourth ventricle is here. It's big and dilated, okay? You can see that here as well. You can see it here as well. But you can see if you just did a decompression back here, trying to say, okay, we're trying to decompress this whole area. Well, there's not much room for that to go backwards, right? And people have done that, and that can lead to lots of problems, okay? You can get worse symptoms if that happens, right? Which you don't want to do. This is due to some instability and then bony abnormalities pushing in front. You can see here, this is another case. This child's kind of in the MRI, flexing a little bit, probably just position of the head. You can see how bad this is, right? So this is your odontoid, the second bone going back into the brainstem and separating really from C1, which is here. Okay, and they have a Chiari malformation in the back. Same thing here. You can see same thing here. You can see same thing here and same thing here, right? And these are 6 examples of, I don't know, I have hundreds of these, okay? But these have to be, this has to be recognized before you do a type of just standard decompression surgery, right? Because it will not be effective in these kind of cases. So the most common abnormalities are, and this is a kind of a cohort I looked at, I think, back in 2019, from 2003 to 2019 of the patients that we had, and it was about, I think, 600 or so Chiari patients that we operated on, between myself and Dr. Arnold Meneses, and it was so the number I think was much higher now for the last 6 years. But these are 32 patients had this abnormality where the C1 bone is fused to the clivus, which is here. And this is a 3D images for all these patients. You get these 3D images to look at the bony anatomy better. You can see this ring is just fused all the way around. And so the problem with this is you've just taken out this critical, this child's born like this, you've taken out this critical joint. And this joint between the skull base, occiput, and C1 is what we use for like 40% or 50% of our neck flexion and extension, okay? And so when you take that out, then the rest of the spine has to do that has to take over and do that flexion extension. And so what it does is it creates instability at the next joint between C1 and C2. And that's what happens here. In this patient, you can see this C1 is fused to the clivus. Again, here, the skull base. So then this is the second bone, which is also fused to the C3, and that it creates even more of an instability between C1 and C2. This bone should be way down here, okay? This patient has clipal file abnormality, okay? And they have this thing called C2, C3 segmentation failure, where this is fused together. You can see the bones being fused. And it creates this gap here and such, and this creates instability. So these patients need more than just doing a standard decompression in the back. They have to be realigned and stabilized. The other thing is that then the skull can move a lot on the first bone in the neck. And in an area that's already compromised in space, decreased space in the posterior fossa, decreased opening in the foramen magnum. When you start having movement here, even just a little bit of movement, as I talked about this morning, even just a little bit of scar tissue, same thing here. Just a little bit of movement can make this even more compressed, and that creates not enough space and instability here, and causes the Chiari malformation or obstruction of CSF flow to be worse. So we call this kind of a shortened clivus and condylar hypoplasia. It means the joint here, which are already flat but are really flat here and very small. This is a little nubbin that sits on C1, and they can move around. As you can see, this is supposed to sit like right flush into this and be bigger, and it can move around a lot on C1. This is showing how we've kind of made this. We don't want to make things more complex, but the heterogeneous disorder that I'm talking about here, Chiari and these bony abnormalities, does necessitate something that has to be a little bit more complex than we initially started back in 1980, okay? And with new technologies and new instrumentation and intraoperative ability to view the spine in 3D with an intraoperative CT scan, we've evolved all the way now to this update we did in 2015 and an update now in 2022 of kind of our treatment diagram of what we do, of how we get to this point. And for anyone that comes in that I see has an MRI where I can look at the MRI and say, okay, there's something, this doesn't look like your typical Chiari malformation, it looks like we have a bony problem or a ligament problem, they get multiple other images. And they need a CT scan with a 3D reconstruction, like I showed you before, so we can look at the bone. MRI is not good at looking at bone. MRI is good at looking at the soft tissue, it's looking to get the neural tissue, CSF flow, but not the bone. Then we get a CTA, so we get an angiogram, not every patient, but if it's abnormal enough, I want to see where the vessels are running, because that can create a problem if they're running abnormally and you expect to do a standard dissection, when you do surgery and then you hit, the vertebral artery, that would be bad. So we want to know where the vessels are. And then we get a MRI, and we get it so that the patient's in neutral alignment, and then we flex and extend the neck. And this is done in kids. This is done in people who are intubated or sedated. And the chin, I always tell our techs, the chin's got to be touching the chest, so it's got to be a true flexion. Let's try this maximal flexion and then a maximal extension. And the goal there is to be able to look at the movement of the spine. We don't do CT just because if you do CT, it's a lot of radiation. That would be three CTs to do that. And and the MRI gives you the ability to look at the neural tissue at the same time as that motion. See, is it impacting the neural tissue, brainstem more in flexion versus extension, and so on. I also get X-rays as well, but those are the critical things. All right, so MRI of the brain and spine, flexion extension MRI, CT with 3D reconstruction where the skull meets the spine, cervical neck X-ray so I can see your normal alignment, because all these other images you're laying down, right? So I want to see if the bone is changing while we're standing upright, especially in someone that's going to have hypermobility, or they're going to have some kind of connective tissue disorder. Oftentimes you'll see significant changes in the curvature of the spine, in the neck, when you do X-rays when they're upright, and gravity is taking a role. So as I mentioned, we have to do more than just doing a fusion. That's the approach that I take with this, and that is realigning the normal spine. And we do that in a couple ways. By placing patients in traction in the OR while they are under anesthesia, and then we give complete muscle relaxants. So they're pharmacologically paralyzed, okay? And we do have neuromonitoring taking place during this time. The goal here is to try to use traction on the head and help realign it. This may not be perfect, but it does a pretty good job actually, especially when you put them under paralysis. But additionally, you can do other additional maneuvers while you're doing the surgery if you need to. And not every time we have to do this, but sometimes. And then what we do is distract. So we can take these instruments, and they're called distractors, place them on one screw and another screw that we place into the spine, and then separate and distract the bones into more normal alignment. So here's a case of that. So this is a patient, Whipple-File and Chiari malformation. So here's C1's fused to the clivus, C2 and C3 are segment are fused. There is descent of the tonsils down here into the spinal canal, brainstem compression from the front and from the back. We put our screws in at C2 here. This is C3 because they're fused already, so you're not losing any by putting screws into either one of these bones because they're already fused together, but it just makes a stronger construct. We place a plate back here with screws into the skull. And then they're in traction, and it's a pretty good reduction, but you can even just a little bit more of this distraction. And these are bilateral distractors, okay? And I basically compress them so they're pushing this out, and this goes down. And I'm just trying to move this a little bit. Even that little bit of motion will help tremendously, okay? So you can see where we move the second bone now is down to here compared to where it was before, okay? And then you can see how much now, there's no more compression in front, and You can see there's no more tonsil descent. This fourth ventricle now is normal in size because it's no longer being obstructed, so CSF can flow normally. There's CSF around the tonsils. The tonsils are rounded. They're not triangular in this shape. Okay. This patient had multiple symptoms, swallowing problems, headaches, balance problems, and almost all of her symptoms resolved with this. I think she's like 4 years post-op now, doing well. So in this cohort that we studied over that period of time, and 109 patients underwent this realignment decompression fusion. All these different bony abnormalities I kind of discussed before, and really improvement in 96% of patients, right, in their symptoms. So showing, really effectiveness of this approach to treating these patients, which are challenging. I'm going to go through a lot of these cases, and I'm just trying to highlight how this is not your typical Chiari malformation, and just so that everyone's aware that, hey, these patients are different, and hey, we have to, look at these in a little bit different way, and not just jump to doing some kind of posterior fossa decompression. But so a 16-year-old boy presented with nystagmus, and then when I saw them in clinic, we had these images, and I said, is this severe? And nystagmus is one of the things I said in the beginning was, this is one of those symptoms that's kind of near the end. It's like of that, all these symptoms, and it's challenging. Once the nystagmus sets in, it's a brainstem real problem or cerebellar problem. If it sets in for too long, they've had it for too long, doing a decompression and such, and they may have great imaging at the end. It may look great decompressed, but the patient will still have nystagmus because it's permanent damage, and that can be really debilitating. So it's like, okay, well, we're going to have to do surgery. And then before surgery, the patient developed all these other problems: hiccups, balance problems, swallowing difficulty, sleep apnea, and weakness. The most amazing thing, I think, this kid did not have any headaches, just presented with these other symptoms. And prior to surgery, he started limping, and it was really quick, right, over these periods of weeks. And so we caught it really kind of just in time. You can see here this bony abnormality here being pushed anteriorly. You can see how thin the brainstem is here, right, in here. Brainstem's pushed down all the way down to here by the tonsils of the cerebellum and by the anterior compression. It's not the best image to show you things, but it's showing you that he has this a fusion of C1 to the skull base here. So this patient has not just this Chiari malformation; they have all these other problems. We call it the fusion of C1 of the skull is atlas assimilation. You have this widened atlantodental interval here with atlantoaxial instability, basilar invagination because of the bony problem and ligament problem, acute clavicle-canal angle because of these issues. It's ventral brainstem compression, and this is just brainstem compression showing what we call, this is the cervicomedullary buccal where the brainstem's pushed down. And there was a syrinx down here. I thought that was related to this. So we got a CT and a FlexX MRI patient, and this is showing the closer up views of all this. And then went to the OR. This is the O-arm. This is fluoroscopy. We use all these techniques to treat these patients. Patients in the traction. We do this this is showing you before we do the decompression, the C1's completely fused the occiput. Ultrasound after we take the bone off and such, showing that it wasn't good enough, and we had to open the covering of the brain in this case, which is here. And then we used the patient's own tissue to place to create a duroplasty, which is here. We open up the fourth ventricle here intradurally. We do this distraction maneuver, and we place the patient's own rib here bilaterally to fuse the skull to the second bone. This is a 3D view post-op, like 6 months post-op showing the fusion. And here's your 6-month post-op MRI. And the compression you see in front is gone. This is the C2. It's right next to C1 where you wanted to see it to. This angle is much improved. You can see now fluid around the cerebellum. And this patient, all of his symptoms, resolved except for some sleep apnea remained, likely some permanent damage. It's a 5-year-old boy, had Valsalva-induced headaches, swallowing difficulty, choking, snoring. And again, this patient doesn't have typical Chiari malformation. You see on a CT, you see chondral hypoplasia, and you have the C1, C2 instability on flexion extension. Again, this basilar invagination, this kind of acute clavicle canal angle. You can see how there's no CSF here. This patient went to the OR, and we did a fusion, and an extradural decompression only was all we needed to do here, not open the covering of the brain. This is a patient, 9-year-old girl, This is a familial type of Chiari malformation. Her brother also has a Chiari malformation, and her younger brother was found to have a Chiari malformation. She has another brother who does not have a Chiari malformation. I follow this family. And the son, who's older, had another surgery done elsewhere and had complications because all he did was a decompression. And he is very much Chiari. He's very much like his sister. And the big issue here, it's hard to see exactly, but in this, but there's a lot of this black tissue around here, and she has some bony abnormalities, including chondrohypoplasia and this clivus hypoplasia, and this brainstem compression from in front. You can probably better see here. So we took her to the operating room, did a decompression, OTA, C2 fusion. We did duroplasty, and this is a classic case where you can see the pannus is completely gone. The scar tissue around C2 is completely gone from what you can see here. All that black that's being produced before is trying to stabilize this part of the spine. Once you fuse that, that goes away completely. And you can see how nice this looks. You can see this is bigger afterwards. And the reason is because this child has connective tissue. His family has a connective tissue disorder. We saw have them see genetics, and they found a mutation in them that is consistent with a connective tissue disorder. And you'll see a lot of times dural we call that an enlargement of the dura. And now that we did this decompression, they have this space. And so then the dura enlarges more because our graft usually just stays like this. It doesn't enlarge this much. And so that's what you see here, which I found interesting. Not every patient, as I mentioned, with all these conditions needs a fusion. And this is one of those cases that doesn't. It's a 28-year-old woman. All she had was paresthesia and numbness in the left arm. Okay, she does have some chondral hypoplasia. It means the skull base is a little bit shorter and flatter, so there's more motion there. Okay, and some people say, well, that's a very acute angle, but really, I look at that. I don't think that this is that acute. Maybe it's 115 degrees. Okay, and there's CSF in front of the brainstem here. Okay. And really the problem is just the syrinx causing her symptoms. Okay? So the goal was just to open up the CSF pathway, really. There's not really this problem from in front. And you can see this is a syrinx here, and post-op, I'm just doing extradural decompression only. It's not, not even opening the dura. The dura expanded a little bit back here, and her syrinx completely deflated, and her symptoms improved. So the summary is that these patients where they have these abnormalities, congenital bony or ligament abnormalities, they need further imaging to determine whether they need to do a fusion or not, whether they have instability or not, whether they have anterior compression of the brainstem or not, whether that's contributing to their symptoms or not. And that helps to kind of determine whether they need a fusion. The other cases, which I'm not going to talk about here, are kind of failed surgeries. And they have maybe a poor dura, ligament, or muscle closure during a previous Chiari surgery, maybe due to a pseudomeningeal or weakened neck musculature. In some of those cases, and most of them may have misalignment where the skull meets the spine. Some of these patients may need to have a fusion afterwards. It just depends. Especially they have kind of progressive changes or kyphosis of the skull on the spine, instability, and then ultimately brainstem compression from in front. So with that, thank you.